Hello, hello. Hey everyone, Dr. J here. So welcome guys. I'm on Instagram Live to bring you guys a whole bunch of different goodies for knee pain. And especially if you're somebody that deals with knee rehabilitation and you're going through knee rehab or you feel like you might need knee rehab, we're going to be on live with Dr. Stacy, aka the Physio Fix, very renowned therapist. I love everything about what she does and what she stands for. From the style of treatment, she's treated a lot of different D1 gymnastics players. She's been involved with a lot of Olympic weightlifting. So I just wanted to jump on live. We have tons of questions that came in. So if you guys are here right now, like welcome guys. This knee rehab, so I'm going to bring her on right now. So let me just kind of figure this out. Instagram has a lot of different things, and I just needed to kind of figure out how to kind of bring her in. So give me guys 1 second, guys, as I bring on Dr. Stacy. Okay, and here we go. I found her. And again, if you guys don't know who I am or you guys are just recently following me, I'm Dr. Jason Wan, and I am bringing in Dr. Stacy to talk about knee rehabilitation and understanding, just making you a smarter version of yourself. So there's a lot of different things that we can do for knee rehabilitation, and there's a lot of questions from if you're a runner, if you're an Olympic weightlifter, if you have patellar bursitis, tendinopathy, meniscus tears. We're here to cover all of those things. So hello, everyone that's joining in right now. And let me just make sure that she's coming on in. Hello, everyone. So just tune in. We're just going to wait a little bit for Dr. Stacy to come on. And let me just make sure that she is available. Okay, so she should be getting the invite and should be actually getting on in very soon. Let's see. Dr. Stacy, she is, sorry guys for just a small hiccup, but we want to make sure that we get in the second half as, again, another expert to listen to other than myself, because I've done a lot of knee ACL rehab, total joint replacements. Again, we have over 20 to 30 questions that we can answer today, so definitely want to tune in really quick. All right, so she's in the chat right now, so she's actually here watching right now, so hopefully she'll be able to join us in a little bit. So I invited you in, Stacy. All right, perfect. Hello, hello. Can you
What's
hear me okay?
up? Yes, I literally thought I had AirPods, but they're not charged. So we're just gonna talk.
Okay, no worries, no worries. So, Stacy, I'm really excited to be doing a knee collaboration with you because obviously there's a lot of respect for, I mean, if you watch Dr. Stacy's story, she's constantly working with different high-level athletes, and me as well as her, we both love to help people optimize their health, prevent injury, but also help them rehabilitate from different types of things. So, Dr. Stacy, why don't you just, you have a lot of followers, obviously, and I just wanted to, if you don't mind, just introducing yourself, what you kind of do, and just what makes you tick.
Okay, so yes, my name is Stacy. I am on here as the Physio Fix. I guess what makes me tick. So I was a gymnast growing up for 18 years. I got many injuries along the way. I found that there was like this disconnect between rehab and my sport, and I couldn't see how the things that they were doing with me were going to help me get back to my sport. And sometimes they didn't help me get back to my sport, not in the way I wanted to, so I had another injury because they weren't exposing me to the things that I needed to do. So I wanted to be that person. I decided like then and there that I wanted to be the person to bridge the gap between the rehab world and the sports performance world. So that's what I do now. I'm like a strength and performance coach. I'm also a USA weightlifting coach. I did gymnastics like growing up. So those are my two main
Nice.
areas, strength athletes and gymnast. But I love working with everyone and just helping bridge that gap. Depending on like whatever they want to do, I want to help them get there.
For sure, for sure. I love that. Yeah, and just to give a little background for those that are tuning in from like Dr. Stacy's end from the Physio Fix, I'm Dr. Jason Wan. I was not an Olympic weightlifter, but I played basketball my entire life. And as you guys know, there's a lot of different knee injuries that occurs. It's one of the most commonly from jumper's knee, ACL tears, meniscus tears. And, I actually had an MCL tear from playing basketball. I fell and my knee kind of caved in. And so over time, after I graduated from Vegas, I eventually became an orthopedic clinical specialist. I like Olympic weightlifting, but I also have my specialty in being a powerlifting coach. So also, kind of background is that, back when I was working in the corporate world, I treated a lot of ACL athletes. So it's really fun. And I think me and Dr. Stacy, we have plenty of knowledge and plenty of goodies. We have a whole list of questions. We're going to try to do our best to try to get through as many as we can. And we're just going to kind of shoot questions at each other and try to answer from our perspective. So I don't know, Dr. Stacy, do you want me to ask you a question first?
Go ahead. What you got?
Okay. So let's kind of let's talk about arthritis first. Yeah, I'm just going to pull one right out of the hat. This one was arthritis, and it says, how do you approach rehab with arthritis, and what limitations do they have with box squats, lunges, deep squats, etc.? And that's a great question because I know a lot of people, even after the age of 30 and 40, commonly people just over time start to get arthritis. So that's a very sensitive topic, and it's oftentimes a very fearful topic as well.
Yeah, I mean, I think that arthritis is so common. Like you said, like people, it doesn't like, you don't have to be a certain age to get arthritis. Like I was diagnosed with arthritis when I was 12 years old because I was a gymnast and had a lot of like wear and tear on my wrist. And the doctor was like, you have arthritis. And my mom was like, what? I thought it was an old person's disease or whatever. And it just goes to show it doesn't matter. It just basically over the course of your life, if you do a lot of things using your knee joints, yeah, you're going to develop some arthritis. So that basically just means that no longer is the bone smooth, like it's maybe a little bit rougher. So when you're doing things, you might feel some like clicking or popping or catching, but it doesn't mean anything is wrong. So I know a lot of people hear those sounds and they become very fearful and they think that they shouldn't do that movement. But really, like when you come to like me, I'm telling you, we're going to be doing those movements because if we can get everything more strong and stable, then that's just going to help reduce the friction in the knee joint as well, which is going to help with people that have arthritis.
Yeah, absolutely. That's a great way to put it. I mean, I guess I can put my 2 cents on arthritis is that you need to get strong. If you don't have, they always say if any of the muscles pertaining to your knee are deficient in any way, that exposes to your knee like 1/3 extra stress. So, if your quad's deficient, right, that's going to lead to further arthritis down the line. And one thing that people don't really understand is a lot of people when they have arthritis, they want to play it safe. So they're sitting on the couch. You're like, oh yeah, my doctor told me not to run and not to squat. Obviously, you make a lot of your gymnasts and a ton of people squat, which is awesome. And people fail to realize that when you're sitting on the couch or when you're playing it safe, that actually accelerates the arthritic process because it goes to you atrophy, the muscles get weak, and then as soon as they try to do something active, it's like it's putting a lot more stress on that joint. So you definitely want to make sure that yeah, arthritis, while it is kind of like this thing that a lot of people are sensitive about, whether it's be mild to moderate arthritis, is that motion is lotion, so the joints need to be stressed out. You need to, improve your muscular strength, and that's exactly what we promote. We both love to put barbells and dumbbells and kettlebells in people's hands, and it's a forgotten art. 44% of like PTs don't actually believe that kettlebell and barbell strengthening is the way to go. They do clamshells for somebody that has knee pain, that has trouble with squat. Like, I don't think clamshells is going to get somebody back into squatting. I don't know about what your thoughts on that. Like these lower level exercises for these high level athletes, I think you got to meet the demands of like where they want to be, right?
Yeah, absolutely. I saw someone's program today with knee pain and they wanted to get back to running. And the therapist that they were working with before had them doing mostly body weight exercises, clamshells, like all that, the basic stuff, and no jumping, nothing to like get them back to what they wanted to do. So it's like I mean, you have to expose yourself in the ways that you want, the tissues to lay down and form. So graded exposure, I always say, is the name of the game. So it's just like,
For sure.
everything is just gradual. You don't want to do too much too fast. So that comes to my question for you then. From our list, this is a good question. Why, no, hold on. When do you go to the doctor? So how much pain is normal?
How much pain is normal? That's a good question. I mean, I think one of those things is like it's very individualized. Like pain just for anybody that has dealt with knee pain or anywhere else, is that pain is a multi-dimensional experience. So pain is not just due to structural cause, but it's also a lot of the psychosocial factors. Like I'm sure that you've had ACL athletes or people that have had different surgical things, and there's a lot of fear. There's a lot of fear components to it, right? It's like, how can I actually load? Can I actually land on my surgical knee again? And that kind of plays into the pain experience, right? If they have any fears or deficiencies, it doesn't matter how strong they are, they're still not going to be ready for sport. So that kind of, it wasn't necessarily a tangent, but I would say, when I think there's a lot of therapists or even doctors, when something hurts, they say, hey, like stray away from it. Like, oh, that squat's hurt. Let's do something completely different and let's avoid squats altogether. And that, little do people know, that's very disempowering to the person that says, well, my goal is squatting, so should I avoid squatting? Like, and how do you exactly get back to that? So I always tell people, like, we have to find workarounds. We have to modify the symptoms by, for example, you have pain with barbell squatting, with doing a high bar squat. Let's transition to a low bar squat. Let's do an assisted reverse lunge. Let's try to find ways to work around the pain, so that way we're still stimulating the tissues, we're still strengthening what we need to. So that way, maybe 2 weeks from now, we're avoiding a certain high bar squat, but over time, if we're doing modifications, then we can kind of get back into that squat, which is something that you were fearful of.
Yeah.
And I would say, on that pain scale, that classic 0 to 10, 10 being excruciating, 0 being no pain. If their baseline's a 2, I generally am still allowing, hey, let your pain go to like a 4 or 5. There's not really that really like absolute window, nor will there ever be, I don't think. But I always allow a 2 to 3 increase in terms of pain. Then, if they start to feel some symptoms or they're very irritable, then I might modify. But I say, hey, well, these tissues need to be stimulated. Even though you're having some pain, those tissues are adapting over time.
Yeah.
So that's kind of my take on, how much pain is allowed, and maybe you can give your take, especially because you're seeing more so a lot higher level athletes than some of the people I'm seeing currently at the moment.
Yeah, I mean, like you said, there's not like a certain number that works for everyone. It's very subjective. Pain is, a very individualized experience. So we kind of like discuss pain. If someone's experiencing it, like tell me about it. Like how long, when we do something, how long does it last? Or, is it resolving within 24 hours? Like, is everything else kind of progressing in the right direction? I'm really not very worried about pain. People are like, you literally don't care when we're in pain. I'm like, just keep going, because most of the things are like
Yeah.
a tissue tolerance problem. So I know that if we get the tissues stronger, that eventually the pain will subside. Now,
Yep.
convincing some people is hard to do that, especially when they're in pain. But I feel like with my population, it's a little bit easier because they know when they come to me, that's kind of the mentality I have anyways. And I'm
Yeah.
them a little bit, and they're okay with that because they know that it gets results, and obviously they want to be out of pain, and that's what's going to happen if they follow the plan.
Yeah, absolutely. That's a great, and again, it's so individualized because we're treating different populations. You're constantly, I'm looking at your stories and it's like high level gymnasts that can like do backflips, right? So I treat none of those people. I treat like the desk bound professionals. And so some of your clients, they're 16 to 20 something. I'm not sure exactly the age group, but a lot of times they haven't had enough time for the pain to settle in. So a lot of times you're treating like acute knee sprain versus I'm treating a person that repeatedly had dislocations. And a lot of times when you have chronic issues, you have to treat the person, not the pain. And so what I'm saying there is they have a lot of kinesiophobia. They're afraid to load their knee. They don't want to put pressure onto the knee. So a lot of times you do need to say, hey, allow this amount of pain. But over time, as those tissues adapt, and you said the name of the game, it's like progressive loading and symptom modification. Eventually they're going to build up, like I like to use the word capacity, right? You have a certain capacity for loading. And if you consistently overload your capacity, it's going to result in flare-ups and inflammation. But if you just meet that sub-max capacity, like understand where your baseline is, which is why people hire me and Stacy, is to understand where your capacity and your baseline is. You meet your capacity, so that way it pushes up that capacity line. So that way, as runners or squatters, they're able to do more over time.
Yep. Yeah, I consider it a buffer zone. So I'm like, I'm trying to increase your buffer zone. So this is like what you need to
I
do.
use that all the time too.
Yeah, that's what I say to patients, and they get it. It makes sense. Like if we can increase that like level, then obviously like now you can do even more things without fearing like a flare up.
Yeah, for sure, for sure. So I got my next question lined up for you. And this one, we dive into a little bit of the anatomy. So I don't know, let's talk. This one came up a few times. Like, when is it safe to return to normal activities after a meniscus tear surgery. So there's a little anatomical one here.
Well, yeah, and then it's depending on, is it a meniscus repair? Is it, a meniscus, just a meniscectomy? So they just like remove it and it's gone. And, you didn't have those weight bearing restrictions. You probably don't have the same amount of atrophy if they just removed it. So when is it safe to return? Me, myself, and I, and everyone within my facility, we do testing. So I know not a lot of other clinicians, I'm sure you do testing too, but I know a lot of people don't do the right testing. And so they have no objective measurements to see like, hey, this is what your left leg is doing versus your right leg, and
Right.
what I want to do is make sure that we're within 90% of that other side. And if that's your
Yep.
dominant side that you had the surgery on, I want it to be closer to that 100%. Like I want you to be as symmetrical as possible in all these various areas, of strength and stability and balance and muscular endurance and plyometrics. Like literally the entire test takes an entire hour and people are dead at the end of it because it's
Yeah.
important to test everything, and you want to see what they look like under fatigue. So if you can show me that you meet those standards that I have, then you're ready, and it's different for each person. So there's no like hard and fast, like 4 months, 6 months. It really depends on
Yep.
how you're doing day to day.
Yeah, you answered that question perfectly. A lot of people are like, I need an absolute answer, right? Is it 6 months or is it 9 months? And truthfully enough, again, pain is a multidimensional experience. So if they're having a lot of pain, or let's say they have a lot of strength, but then you put them on like a readiness to return to sports scale, and you're asking them a few questions, and all of a sudden they're scoring like a 45 out of 90, for example. They're not ready to go to sport, psychologically. And I like that. Like 90% of the uninvolved leg is what I go with too. And it's dependent on what their sport is. So if it's like a basketball athlete and they need to jump a lot, I'm doing like a tuck jump assessment and I'm seeing how their form decays over time after 10 jumps, right? Or I'm having them doing like single leg hops across the room and seeing like how fast it can get across or what their distance is. And even quality of motion, quality over quantity is really important. So I like how you said that the objective data determines when they are ready to go. Because what can't be, I say this all the time, especially like in our businesses, what can't be measured can't be managed. So if you're not laying down the data and actually using objective mathematical data, then you're really just as a physical therapist, you're kind of second guessing when they could return to sport. You're like, oh, you look pretty good. You can jump almost the same distance. You're good. You're good. But hey, I mean, like you really need to load them up and really see how they perform under fatigue, like you just said. So you answered that question perfectly.
Yeah, and we actually just got a new crane scale. I don't know if you have one. So it's kind of fun to like, to be able to actually measure that output too, to see how much force that each side can produce. And then obviously,
Yeah.
compare the one versus the other as well. So it's just another way that we can see if they're ready.
Yeah, yeah. I don't have those types of things in my gym. I rent a gym from in San Francisco called Body Mechanics, and we don't have that type of leverage at the moment. But man, I'm jealous of you.
It's not that expensive. You can just like make your own from like Amazon. I think it was like $80.
Okay, for sure. I'll take a look at that in a little bit.
Okay, so you need a question. Let's see. Um, knee snapping or cracking while squatting, is that okay?
Ooh, that's a good one. That's a good one. I'll tell you this. I mean, since I was 16 years old, every time I did a deep squat, it was always like it would always snap coming back up,
Yeah.
right? And people really, you mentioned it earlier that snap, crackle, pop really does induce a lot of fear, especially when people are like, "Hey, I used to not have that, and now since I'm older, now I'm starting to deal a lot with that snap, crackle, pop." Or they feel like that sandpaper type feeling like underneath their kneecap and whatnot. And to be honest, if you are functional, please don't worry about it. If you're not having pain with the snap and crack, it's perfectly fine. Now, for example, if you feel like a strong snap and all of a sudden your knee starts to swell, okay, go ahead and see me or Stacy, right? And go ahead and like make sure that you're taking the right measures to get an assessment. I say all the time, assess, don't guess. But truthfully enough, that's just called crepitus. It's just normal types of tissues when cartilage is changing. As we get older, people don't realize that sometimes cartilage in certain areas or like synovial or like plica actually gets thicker over time. So there's like less space into those compartments. So when you do actually deep squat and then you're coming up and you feel like a snap, if it's not painful, keep loading, right? And people are like, well, Jay, my goal is to get rid of the snap. I'm like, well, is the goal really to get rid of the snap or is the goal to become functional? And I would say usually the goal should be to improve your function, not necessarily to get rid of a sound. I'll tell you this right now. I actually had I've had some deaf patients in the past, and trust me, they actually do better than some of my non-deaf patients because they
Okay.
can't hear it. They
Yeah,
can't hear they can't hear anything. They just feel a sensation, but they can't hear it. But when they hear like a, then
yeah.
they're like, oh shit, like I need to step back a bit.
I mean, it's
But yeah,
you start like hearing sounds from your body. I love when people are like, "Hey, can you hear that?" And they'll like, like come closer, and I'm like, "No, it's like within you. You can hear it, but I don't hear it. It's not that audible."
yeah,
I mean, when I squat, one of my knees does crack a lot, and everyone's like, "Oh my
right.
gosh, like, are you gonna be okay?" I'm like, "Yes, I'm gonna be fine. Like, nothing is wrong. It just happens to crack, and that's normal."
Yeah, yeah, for sure. The knee, you actually, I don't know, correct me if I'm wrong. You've had a couple surgeries in the past as well, right?
I've had 3 knee surgeries.
Yeah,
Yeah,
yeah. And so if that says anything to you guys about, I guess, the resilience that Stacy has had, and the resurgeries did not stop her from squatting, what, 235 or 245 recently. That says something about the people that are watching right now. Like, you guys are resilient. We're human beings. We adapt to load. But we also maladapt too. So if you're fearful, if you're just sitting on the couch, you're just playing it safe, you're going to maladapt. It's going to lead to disuse and atrophy, and then you might actually lose the ability to do the activities that you want to do. So you keep loading. That's the name of the game.
yeah, and put yourself in the right environment because you have to have the right people around you to like tell you that it's okay to feel these things because a lot of doctors are like fear mongering. They'll make you more scared.
Yeah,
And I hate to hear that when people come to me and they're like, "Oh, well, my doctor said don't do this anymore." I'm like, "But that's what that's what you want to do. Like that's what you love to do." I feel like that is not an answer. That's not a solution to your problem. Like I'm glad you came to me.
yeah, yeah. That's another subject that we can do in a future collab. Is like words harmed, like how the words that certain people use, especially again, even our own physical therapists, older school people will still not understand the words that they use. And sticks and stones make break my bones. Words will never hurt me. That's false. Like words really do hurt when it comes to talking about the body. You're bone on bone. You look like you have a knee of a 90-year-old. Like that's all stuff that I actually hate to hear. And it's almost like you're starting backwards. You're not even on the starting line. You're having to start backwards and really educate them about their X-rays and their MRIs and the fear that it induces in them.
Yep, absolutely.
Yeah. Is it my turn to ask you a question?
I
I
think
believe so. Okay, so let's go into this one's a great one because you treat a lot of female athletes. I know you treat some males, but this would be a good one to answer for some of the females out there. Do women with wider hips have more knee issues due to bone angles?
This is definitely something I learned in undergrad, and I think that it was even touched on in graduate school too. I've also like read a lot of research papers recently that says like, like yes, Q angle is like a little part of the piece of the puzzle, but it's really about like,
Yep,
do you have the ability to control the movement that you have that's happening at your knee? So, being in valgus alone doesn't indicate that you're going to tear your ACL. It's more
absolutely.
into it? Can you get out of it? Do you have the strength to do that? That is more indicating if you're going to be someone that's going to potentially tear their ACL. So QL angles, I don't think they're as important as we used to think that they are. I'm sure the
I
people in
agree.
the bio mechanic world would be like so outraged at me right now, but I
Yeah,
think that it's all about like the tissues, like how are you moving, how are you landing, and if you get into that position and you have kind of like those knees in, like it's not bad. We see like the strongest lifters in the world come out of a squat and their knees go in because it's more advantageous for their bodies to be able to push vertically through the ground and produce more force. Now if you looked at it, you'd be like, oh my god, like that's so wrong, that's going to hurt themselves, their knees are going to explode. But no, like, so it's the same thing with the Q angle. It just basically means that for you guys that don't know what a Q angle is, that your hips are wider and your knees go in. So like the angle between like your hips and your knees is kind of this angle, which is also what valgus is. And like I said, it just is about your ability to control those positions. Um, I don't think that a bigger Q angle indicates anything.
I love your answer. I wouldn't, I'm being absolute with you guys. I'm not like, oh, we're on a live, so I can't disagree. I would disagree if I really wanted to. And I'm gonna name off a couple things. Chinese Olympians, basketball athletes, and Usain Bolt. If you guys know who those people are, Chinese Olympians are some of the strongest athletes in the world, and they're actually taught to go into valgus and a little bit of hip internal rotation in order to generate that vertical force from the ground. Basketball athletes, you look at Michael Jordan, Kobe Bryant, you look at Zion Williamson. all of them go into extreme valgus off that back foot in order to generate force to dunk over people and just crush people with a
Yeah.
50-inch vertical. And they have no, a lot of them, maybe they had knee issues, but they're some of the greatest athletes in the world. And lastly, I'll say Usain Bolt, although he's not a woman and we're talking about Q angles. But my point is, like, Usain Bolt, I don't know if you see him off the starting line, but they actually say he has the worst start of almost all the athletes that are right next to him. He goes into extreme hip internal rotation, his knees in full valgus, yet he crushes his competition every single damn time. So are Q angles, are they determinate? Not really. Is knee valgus bad? I don't think so. I think that some people actually generate force better going into knee valgus. And that's my pet peeve with a lot of like just different, these biomechanic people that really just preach that, oh, it's all about biomechanics. There's a lot of research coming out there that says like mechanics actually don't matter as much as long as that athlete is functional, adaptable, and I don't know. Like we're both very passionate about this subject, obviously, and I really feel strongly that this valgus type thing, it does have to change. Maybe if you have symptoms, maybe you need to modify a bit. But trust me, the athletes I just named off, they're high level athletes that really don't need to change their mechanics. And I would argue that if you change their mechanics, they'd probably be worse off, and they probably won't have as much stability, with their sport.
Yeah, yeah. Everyone has different limb lengths. Everyone has different, pathophysiology. So you got to find what works for your body, and you may go into those positions, and it's fine. So I think that anything, people in there are like black and white answers, like it's not inherently bad. So, your positive Q angle or a wide Q angle doesn't mean anything to me.
For sure, for sure. Love it, love it.
Okay.
We're doing great. We're providing so much value to you guys. I know that for sure. Hopefully, you guys are learning a lot.
Yeah. Let me find you a question. Uh,
All right.
okay. How to tell if pain is caused by ankle, hip, slash tight adductors slash another issue? So basically, how do you know if it's the knee or if it's like the hip or the ankle or something else?
Yeah, I was looking at that question too, and I was just kind of prepared I highlighted it for the person that did ask this question. I don't think that you really separate them. Like, I don't think you say, hey, you have hip abductors, and it's just that. I would say that you have, when me and Stacy, when we diagnose things, we say, hey, you have like an acute bout of knee pain secondary to tight calves, secondary to undertrained hip abductors. So I don't think you really separate them. So that's kind of like a weird question. I wouldn't say weird. Don't be offended, whoever asked this question. I would just say that there are other secondary causes to the primary diagnoses.
Yeah.
So that's why when you're looking at all the exercises that Stacy puts out, it's a ton of value, obviously, but a lot of times you can't just say, oh, I have knee pain, so I can just follow this knee program. Like, you really do need to get it assessed by somebody professional. And honestly, invest the time and finances into getting the right exercises, something that's going to be unique to your body. Because if you're asking the question, man, is it like ankle, hip, or tight adductors, then you're really just second guessing. You don't want to just, pigeonhole yourself into a quad strengthening program. All of a sudden, it makes you worse. So hopefully that answers that question, just because I don't think that you really separate them. I don't think they're mutually exclusive items about ankle hip, because there's this thing called regional interdependence, which is essentially your knee is subjected to whatever your ankle and your hip are, and also your trunk. So your trunk stability, your trunk mobility, how much hip internal rotation you have can determine how deep your squat is. And also, if you have tight calves, that limits the descent of your squat, for example. So that's called regional interdependence, which is essentially saying your knee is subjected to whatever the ankle and the hip does too. So that's why we do a whole objective assessment, and we really measure out that data.
Yeah. Yeah, I was reading it like, can the ankle problem or the hip problem cause knee pain? And yes, I feel like anything can cause knee pain, right? It's not saying that this, even if you have tight ankles, doesn't mean that's the reason why you have knee pain. Or if you have, tight hips, it doesn't mean that that's the reason why you have knee pain. And then also I was reading it like maybe like a chicken or the egg thing, like does one cause the other? And we don't know, we really
Yeah.
have no idea. When I do an assessment, I say like, okay, this is what I'm finding, that, this could be improved, and this is, tight, and this is weak, and this could, use more movement efficiency, like whatever I'm finding, I'm like, these are the things that we want to work on, right? I'm not saying like, I think that this is the reason why you're in pain, because nobody really knows. You know, it could be that reason, or it could be something else, or it could be a combination of 7 different things. So I think that like you can't ever tie it to one thing. It always depends.
Yeah, yeah. I forget which research article, but I think you're on to exactly what it was, which is like a lot of times people get weak hip abductors, and you start to see them go into valgus. Well, was it the weak hip that caused knee pain, or was it like the knee started hurting and therefore the hip got weak?
Yeah.
And so it's huge. It's like, we don't have, we're not God, so we don't know exactly what caused what. Again, it's the chicken or the egg. We just know, we just tell basically that we give you the objective data, we give you exercises to work on those dysfunctions, and therefore you build up your capacity and you get back to the sports and the activities that you love. That's essentially what it is. That's what we do. We're movement experts.
Yep. And detectives
Yeah.
too.
Detectives, absolutely, absolutely. So I think I'll ask you a question about running. And so this one is just, let's talk a little about running, just because there's a lot of runners out there. There's a huge, obviously, hashtag runners community.
Not me.
Okay, but hey, like, maybe we can dive into this a little bit, because maybe you should talk about like tissue tolerance and everything. But, knee pain from running for 4 months, not sure what to do or how to get rid of this. That was the first question that I got on my list. But I don't know, when you see runners or even like your gymnasts that have to like sprint across, the platform, what would you say to a person that's struggling with running for 4 months?
Man, I mean, I would have to do an assessment, right? Like you just don't know what's going on without seeing someone move and kind of looking at things a little bit further. And that doesn't mean you have to put your hands on someone. Like, you do online program too, right? An online.
I believe, yep, yes, I do.
Yeah, so I do that too. Today was my telemedicine day, so you don't actually have to go see someone in person for them to be able to accurately like assess you and like figure out what's going on. Just gonna throw that out there, guys. But for knee pain with running for 4 months, I would want to know like, okay, what is first, the running form does not matter to me. I don't know about you, but I find that it's really hard.
I actually say mechanics don't matter as much. And I've been to plenty of running seminars as well, and
Yeah.
a lot of them agree running mechanics don't matter as much as people think.
Yeah, and if you try to change someone's running, first off, it's really hard. And second off, it could cause something else to change, like further up or down the chain. So you could cause another issue, which so we don't work on that. So I would look at what is your, like, your landing. What about jumping? Like, so all these like force production, force deceleration. What does it look like when you're doing it? Let's slow it down. Like, where is the faulty, movement happening from? And then like, when can we reproduce this? Like, what are you doing when you're doing that? So I think that, you'd have to figure out what's going on and, make sure that, if it's just more of like an explosiveness thing and maybe that you're just not, your body isn't ready to handle that amount of force and that much repetition. Well, we need to, that's a volume problem, right? That's a tolerance issue. So we need to increase your work capacity to be able to handle that. And how do we do that? If it's more of that explosive dynamic, then you do plyometrics. You do things that are like that. You do, you increase the reps that you're doing to get your body ready to do even more. So then you just become immune to it, and I don't know about you, but it's hard to answer the question without seeing, the person, but that's my first thing. I would look at what the movement looks like itself, and then breaking it down and slowing it down and seeing, what you can find.
Yeah, yeah, the first thing that you said, it was like music to my ears, like mechanics, like, again, there was like a world-class Indian runner, and he always ran with books in his hand. So he actually developed this dysfunction where he runs with like a chicken arm. He actually runs like this, but he was actually one of the top 10 runners in the world. And it's like, well, if you change that mechanic, what else might happen? He might actually develop pain elsewhere. I guess just from my perspective, because I am certified in running, and I treat a lot of the long distance runners versus you probably train like more so like the power athletes and people that have to sprint across. It does come down to a few things. One is just cadence. So, if your cadence is too slow, you need to put your foot down faster. A lot of times, yeah, single leg stability. People fail to realize that running is a single leg sport, thousands and thousands and thousands and thousands of times. So you have to look at single leg stability, single leg squats, single leg RDL. And then I do actually, this is one thing that maybe you're not aware, but like I actually like to see how they run without shoes versus how they run with shoes, because
Yeah.
a lot of times they run without shoes. They'll be like, oh no, but I need the support. And a lot of times you get them running on treadmill without shoes, and they're like, oh shit, my pain's gone. And so they've actually that means that they've actually developed a positive adaptation, and they may actually need to switch from like a Hoka, which is a lot of them are like a super stiff shoe, and switch to like Vivo Barefoot. But not that drastic of a change, but find something on that minimalist scale that kind of meets that demand. A lot of times you strengthen the intrinsic foot muscles, you strengthen the ankle complex, and a lot of times you'll see that their knee, their hip, and their low back pain goes away.
Yeah.
And it's huge. They actually say American podiatry, we actually get it wrong. So they actually put kids in like these cute Disney shoes. While I want to put my kids in these cute Disney shoes, they're actually like blocks. They're so stiff,
Yeah.
and they actually develop plantar fasciitis and knee pain. For some of you parents out there, and all of a sudden, like French and Canadian sports podiatry, they're like, oh, well, actually, let your kids jump around barefoot.
Yeah.
Because if they do that, their feet become extremely resilient and they have less dysfunction down the road. So that's my take on the running part.
Yeah. Most people that I see, if they're a gymnast, they don't wear shoes anyways in here. But
Exactly.
and they definitely have really strong feet because they do their entire sport barefoot. But shoes is definitely a big issue. And I don't know a lot about, the different like shoe types with like running and like the drop and all that stuff. But I do know that there's places out there you can go that they will help you out. And that could be part of it too. Like, like you said, you're wearing the wrong type of shoe. And I'm not the person to go to for that because I know nothing about that. So you got to find someone that knows more than I do.
Yeah. No worries. I mean, there's going to be different sports, different therapists. And so, yeah, I mean, I do running assessments, but for the most part, you know, it is about capacity at the end of the day. I mean, the overlying thing on how to answer this question is about capacity and knowing how to quantify your stress better. And if you don't have a good understanding of how to quantify stress, then you're really just constantly overtraining. 90% of most injuries, my opinion, they're not freak injuries. Oftentimes it's like it's a training error, and it was actually, unfortunately, it was your fault that you made the training error. Switch to a different shoe, squatted too heavy, working out too frequently, not taking enough rest breaks, like all those different parameters.
Here's a question for you. Is it overtraining or under recovering?
I heard that. Oh, I don't know who actually told me that, or maybe I saw that on Did you do that one?
No. I just said mic drop. So I'm out.
Yeah, I don't know if it's such a difficult question. I'm like,
I think we don't
well,
definitely don't know. It's another chicken or the egg thing.
yeah, because you can, honestly, you can do as much recovery as you can. You can try to get as much sleep as you can. I can't. I have an 8-week-old, so I'm lacking sleep. So I need to understand how to scale back. But under recovering, as in like doing the right soft tissue mobilizations before sport, or like, doing the right recovery things to decrease DOMs, not training as frequently. But yeah, I mean, honestly, I would say people can actually overtrain. But at the same time, overtraining is a product of, you just take the oxymoron version of it. It is under recovering.
Yeah, I think
So it's a tough question. That's a tough one.
it's literally the same thing. It's just like, the
Yeah.
different end of the same sword.
Yeah, for sure. For sure. Is it my turn to ask you a question?
Um, you just asked me about,
Let's just go with you. I'm gonna ask you a question. Oh yeah, you did. Yeah, we'll take the under recovering as your question.
yeah.
Let's talk about tendons. I love tendons. I love my tendons. So common beginners knee tendon strains with squat. So I guess like what are common, I guess, interventions or what they should be thinking about in regards to like a knee tendon sprain and somebody that has pain with squatting.
All right. So I don't remember where I heard this, but the only language that tendons understand is load. That's it, right? So tendons respond to load. So load. And if we can load them through a larger range of motion, obviously we can strengthen and like build that tolerance up even more. So is the question about exercises to select?
It wasn't even a question because some of them don't put a question mark in the back of it, but it was more so just like for a beginner, knee tendon strain. So that person might be dealing with some sort of like quad tendon, or maybe it's the patellar ligament, not necessarily the tendon. But if somebody had pain below the kneecap, above the kneecap, what are maybe some common interventions that you might prescribe? And again, it's still unique to the person. So again, assess it,
Yeah.
don't guess. They'll still come to see us.
I would say definitely I do heels elevated goblet squats, or always heels elevated to get that full range of motion. And then we want to get full range of motion on both ends of the spectrum, right? So we want to do full range of motion in the heels elevated, and then we do Spanish squats or like a TKE variation because you want to strengthen at the top too. So you got the bottom, you got the top. Then like doing things that are like same sort of thing. You're gonna, do like an elevated reverse lunge, sort of thing, or you could do, wall squats or wall sits to just increase, isometric capacity too, because that's, something we can also improve. So those are like basic stuff that we like start with, and then obviously you branch out based on like what the person needs, their goals, their sports, etc.
Yeah, that's exactly what I would do too. Just harping on the fact that like tendons, tendons connect a bone to a muscle. So, when the muscle is pulling on the tendon, a lot of times that tendon will shear and they'll like rub underneath certain structures. But like tendon, yeah, the name of the game is load at the end of the day. So, if they can't tolerate plyometrics, that means that tendon is being overly strained, right? Force production. So the higher the velocity, the higher the stress on the tissues. So sometimes you can't just keep jumping and expect your knee to feel better. Sometimes you do need to scale back a bit and maybe do like a low load, long duration stretch. So maybe a lot of times I like to get people into Spanish squats. I like to get people into like either an elevated or just a flat foot single leg squat isometric. And if they can't tolerate that, get them into a lunge isometric. So at least you're loading either the patellar ligament or the quad tendon, wherever their tendon issues are. You need to build up stress. And there's a lot of research saying like, hey, if you do like isometrics for a long duration of time, that significantly decreases pain. It's almost like an analgesic property to it. And then once they feel more confident after their knee is hurting less, then you get them into the dynamics movements like a barbell squat or then getting back into plyometrics. So yeah, the tendons are,
And
I don't know about you, but I love tendons.
open chain exercises, like they're not bad, guys. Like you're not going to destroy your knees. Like knee extensions are amazing for tendons, right? We're strengthening through a large range of motion. They are great for our knees. So that would definitely be probably another basic one that I add into.
Yeah, especially the ACL athletes, so there's all that research about like, oh yeah, you do like closed chain and you only do like 0 to 30 degree squat, right? Or like avoid 90 to 45 degree knee extension. And all that has been disproven. And I would say it's actually a discredit to our ACL surgical athletes that you're not doing open kinetic chain knee extension. Like that's a no-brainer to me. Especially I love to do blood flow restriction training where you blood flow restrict them and you do 2 seconds up, 2 seconds down, and you load them with a band or knee
Brutal.
extension. So that there's so much more quad gains in the initial phases of ACL, and that you're doing them a really huge disservice that they get denervated, their quad doesn't work 8 months out because you're not doing open kinetic chain knee extension.
Yes. BFR all the way.
Yes, for sure, for sure. Um, so let's see. Um, Maybe I'll ask you another question, but can uneven or rotated hips cause knee pain while squatting? So that's a little bit different from the Q angle, right? It's more like about rotation. So what would you say about that?
Sure. Anything, like I said, anything can cause knee pain. It's not like, it's probably more like a subsequent finding. Okay, like your hips rotate, like you're shifting. I think that's probably what they're talking about, like some shifting happening while you're squatting. Okay, is it the shifting that's causing the knee pain, or is it the lack of the strength at that knee which is causing you to shift? I'm sure that is probably more likely the answer, but yes. So that is more of a reaction that we do, or a compensation mechanism that we do when we don't have, a strong of, a movement pattern, or the muscle is weak, or whatever you're trying to do with squatting, so I don't know. That's how I would answer that. It's yes. It
Yeah, yeah, yeah. I don't think that's a wrong answer at all. I think that's actually perfectly correct. And uneven rotated hips, at the end of the day, it's a strength issue, it's a mobility issue, or it could be both, right? So if you lack hip internal rotation, then you can't really dive deep into that hip socket. So therefore, your knees have to translate forward, which causes your heel to lift up. Or, if it's a deficient hip abductor or the hip, these deep hip internal rotators that can't sufficiently stabilize the hip. So therefore, it ends up translating to more distal issues like knee strains and whatnot. So you answer the question right. That's kind of like a oddball question that we like at the end of the day, in this middle of this conversation, we already said that mechanics, they don't matter as much as people think. And anybody that kind of says, oh, you have to shift your knee out, you have to shift your knee this way, you have to do it exactly this, they're pigeonholing you into, the millions of other knees that they've seen. And again, that's not the best way to treat the person. They're just treating the pain.
Okay, should we do more of our questions or more of some of these questions that we're getting?
Oh, yeah, actually, a lot of the questions are coming in.
That last one, what do we think about over toes?
Oh, did somebody ask that question?
Yes.
Ooh, so
Passionate. So
yes. So I actually did like a little sarcasm post, and I like to be sarcastic sometimes, so pardon my cynicalism sometimes, but um knees over toes. It's not wrong. It's absolutely not wrong. If you have a lot of symptoms, then translate your knees further back or modify the technique, maybe do some different exercises that don't directly load the knee as much, but it is not bad to bring your knees over your toes. And I actually posted a 2003 article just today on my Instagram about how when you bring your knees forward over your toes, it only really increases the stress to your knee by about 28%. And you guys might be thinking, well, why would I increase the stress to the knee? Well, again, the name of the game is loading. But however, what the research showed was that for those that actually shift their hips back and keep their knees behind their toes, which is again, majority, it's 1,073% increase stress to your hip and your lower back. So I don't know about you, but I prefer to build my capacity to my knees, which is what you're coming to us for,
yep.
rather than waiting for a hip labral tear or like a disc herniation to happen. 28% increase in your knee versus 1,073% increase if you shift your knees backwards
Yep.
um, is a no-brainer to me.
Yeah, yeah. For me, when I like see like power lifters and weightlifters, like if they're like a high bar squatter, they're probably more putting their knees in front of their toes, which is like you said, absolutely fine. Like that's you have to do what's right for your body and what feels natural. And if that's natural for you, do it. Don't limit it because it does cause extra stress if you do, limit that range of motion. So we do see that like the people that do high bar squats, they use, they have stronger knees, stronger quads. For those that do like more low bar squats, and they shift that weight back, they usually don't let their knees go over the toes. And I see, I don't know about you, but a lot of those people come in with a lot of hip problems and a lot of low back pain because, like you said, that 1,073% increase in the stress to the low back and the hips when you don't let your knees move naturally.
Yeah, yeah. I mean, you're gonna whatever shoes you wear. I mean, shoes is another subject, but even if you're a low bar squatter, I would honestly say that you should still strengthen your quads. Like, don't depend on your really large and while you might have really strong lumbar extensors because you deadlift a lot or you have strong glutes, at the end of the day, if you're not strengthening your quads, squats, no matter people don't know this, but like no matter how you squat, no matter what variation of the squat, at the end of the day, it's a quad dominant exercise. You need to load up your quads in different fashions, like the elevated heel goblet squats or, open kinetic chain knee extension. You need to load your quads. Like, I think it's preposterous for people to think, oh yeah, you can turn it into a glute centric exercise. It's still, at the end of the day, with EMG studies, it's still a quad dominant exercise. So you're a low bar squatter, you still got to translate your knees forward.
Trying to find some more questions. Someone asked,
I had one, I think I had a good one for you.
are you posting?
Somebody was like, well, what about knee mobility for jujitsu? And, I don't know how many jujitsu athletes you see. I've seen a few, but, I kind of know some of the mechanics about it. Like, what are your thoughts on knee mobility for jujitsu?
Yeah, I think for like those type of like martial arts and like fighting sports, you have to think of not about just the knee that moves in flexion and extension, but there is a rotational component to the knee too.
Exactly.
To work that, so you have to work on getting that internal and external tibial rotation, and you have to, like learn how to also like, move within that position. So I think that working everything is really important for that sport because it's not a normal sport and they do a lot of weird things. And if you, what they say, like you always regret the things you don't train, like when you get hurt, right?
Yeah.
So
Yep. Yep.
to train everything and you train the weird stuff definitely because that sport you could be put in the most uncomfortable and weird positions and you got to be able to adapt in that position and be strong enough to get out of it or you're going to have an injury. So
Yeah. Yeah, great way to answer it. Like I would also say like, yeah, again, about regional interdependence, like, yeah, make sure your ankles are flexible, make sure you have a decent amount of hip external and internal rotation because that will translate like if you don't have enough hip external rotation, that is going to put more stress to like, for example, the medial compartment of your knee. And I have heard of people that have really stiff hips that have resulted in a meniscus tear. So you do need to look at that. Also look at core strength at the end of the day. Don't think about just knee mobility, like knee tibial internal and external rotation is absolutely important. But look at your trunk strength. Look at how much anti-rotary stability you have through your trunk. Because if you can't grapple somebody properly, you're still going to result in like a knee injury. So look at core stability. Make sure that your lumbar spine and your pelvis is able to move well too. And like she said, train everything, train everything because that sport is, amongst most sports, you're contorting your body into many different positions.
Yep. I have a question for you. So further up, I see someone asking about Baker's cysts, and they said that there are no tears on the knee, so I guess they've done imaging. What type of exercises should they do to help with the pain and able to bend the knee?
Yeah, I've seen a lot of patients with Baker cyst. So Baker cyst, honestly, my honest opinion, and this might just be anecdotal, meaning by my experience, but I often say that like a lot of the muscles around the knee are just undertrained. So like Baker cyst, when your muscles in your knee are deficient, it does result in hurting some of the structures in your knee, like the bursa. There's a lot of bursa around the knee and in the posterior compartment. And so if your hamstrings are deficient and you're like walking downhill or you're like running, yeah, you're going to put a lot of stress to some of the bursa in the back of your knee, which can result in that Baker cyst. But let's say you're a person that's coming into the clinic right now or seeing me or Stacy. Like in order to relieve the symptoms, you have to look at a couple things. One, get full knee extension, terminal knee extension over terminal knee flexion, in my opinion. You got to get that knee straight. So that's by way of stretching your calves, looking at this little secret muscle also called the popliteus, which unlocks the knee. And that popliteus, if you get that to kind of soften up, you do some soft tissue work there by way of foam rolling, doing what you need to, digging your own thumb into there, that can actually release the knee, which can actually improve your knee extension, and allow that knee to kind of feel better with walking. And yeah, stretch obviously the entire gastroc complex and strengthen your hamstrings. It might hurt initially, but what you need to be thinking about is the hamstring is that main muscle that prevents like anterior knee translation. So doing hamstring isometrics on a Swiss ball or doing like a straight leg bridge on a Swiss ball so that the Baker cyst doesn't hurt as much, you can do a straight leg bridge on a Swiss ball. But ultimately, those hamstrings are super important, and then get that knee straight, and then maybe that little popliteus muscle might be a good thing to kind of work and massage out a bit. What are your thoughts?
I would say let's not forget the soleus muscle, which also prevents
Yeah.
translation of the tibia as well. I feel like people always forget about that. They're like, in rehab, let's make sure we do, hamstring. And I'm like, let's do the calf too. Like, you got to still strengthen.
Yeah.
Like, people don't train their calves, and I think that we need to do that more because, like you said, it's something that's also working harder if it's, if you're having pain when you're doing these certain movements. So I would definitely
Yeah.
strengthen the hips too. A lot of like hip strengthening. You want to see like what's going on. Like, is there a lot of rotation happening at the knee when you're doing single leg movements? Like, how about when your foot's, moving or you're in single leg balance position? What's going on at the knee? Are you having a lot of tibial rotation? Are we causing extra friction? Are we, increasing the bursitis in that area, which is causing that swelling and that pain? So there's a lot of different things that you can do. That's why it's always best to get, a consultation by someone that really understands these things, and you're not just cherry picking exercises off of Instagram that you see.
Yeah, yeah. Instagram is definitely not rehab. We post the stuff for the purpose of impacting your guys' lives and giving you guys ideas. But at the same time, it is really hard. You know, don't discredit the fact that me and Dr. Stacy, we probably have a combined like 16, 20 years of like experience. So, it's hard to say like just depend on Instagram, but really, if you guys really need help, like get an assessment, right? If you're struggling and you're saving all these videos and you're probably saving more of her videos because she has a lot of people. Um, it's that's not enough a lot of times. Sometimes you need to level up and sometimes you need to ask for the help.
Yep.
I'm not sure that there's a tons of questions, like the right shoes for running, like
This one's
I
good.
guess.
It's about the meniscus, and this was someone that asked about meniscus surgery. If you have that mechanical locking, is surgery required? And I would say yes for this one. That is like the symptom that we look for when we think about like surgical versus a
Oh yeah.
route. Like if you're getting that mechanical locking, and you have to like do something different to like unlock your knee before you can move, that's definitely something that you should start looking into getting that surgical intervention.
Yeah, I totally agree with that. Like, there's so many different types of meniscus tears. There's like flat tears, and there's like, just meniscus degeneration. But at the end of the day, one of the main questions that we ask, like, are you getting any locking? Are you getting any buckling? Like, does it take a lot of movement in order to like jimmy it out of position?
Yeah.
And that's oftentimes like as much quad strengthening and other things, you have a passive structure that is not stabilizing the knee properly. So therefore, you do need to kind of get that fixed. But that is when we kind of like result in like, hey, like let's get a surgical consult for that. Um, I guess there was one about bracing. So, this is a simple question: brace or no brace? What do you think?
I'm not a fan of bracing. I don't like relying on external things to provide support. Now, I do, I know there's this placebo effect, and you feel safer when you have something on. But I just want people to know that it doesn't actually prevent anything from happening. It's not going to prevent you from getting an ACL tear or like make you feel better. Well, it may make you feel better, may make you feel safer, but it's
Yeah.
not actually doing much. So if you can go without it, I think it's going to help long term because you don't want to rely on something like that for the rest of your life. So I'm not a big fan of bracing, but there are some surgeons that always still like post ACL, repair. They all
Yeah.
brace, and it's just
Yep.
a surgeon
Yep.
surgeon thing. So sometimes we'll get some patients in here, and then I'll have to talk with them, like, hey, do you think that you need this, sort of thing. Like, I know what your surgeon says because that's just like their protocol because they feel like they want to protect it as much as they can so you don't re-tear, but that's also
Yep.
what we're doing when we're strengthening your muscles and we're stabilizing them. So we're strong enough, we're stable enough. I don't think you need this. So if you feel comfortable, let's slowly get out of it because I don't want you to be using it long term. And most of them are pretty like good with it. Very rarely do I have someone that's like, nope, I'm going to use the brace for the rest of my life.
Yeah. Yeah. There's two quotes I always use for people that like overly brace. One is like, you have your own internal brace, and that's by way of like the muscles and the structures that protect your knee that are actually going to help you long term. And then another thing is trust your joints, don't protect it, right? Because at the end of the day, when you're putting a knee brace on, you're protecting your knees. And the way I see that is like I posted about that. I posted a quote about it. It's like a mother like in a I don't know, like a ghetto area, and she's like taking her kid and she's like holding her kid tight because she don't want him to get stolen or robbed or anything. And that's you're protecting, you're pulling back.
Yeah.
And when it comes to the sports that you love, you don't want to pull back all the time. You want to trust your damn knees and hope not hope, but like you really want to train according to the demands that you want. So if you're going to brace, you're essentially saying that I'm going to protect myself for the rest of my life. And there was a research article about bracing, how when it comes to like those neoprene braces, it actually does help with like the knee extensor mechanism. So it actually pulls you back into the squat easier. And that's something that you also don't want to do because you're not really using your quads efficiently at that end range of flexion. So do you want to brace? Maybe temporarily, but do you want to depend on a brace the rest of your life or like play with one? I would say not. Like rely on your own internal brace and start to trust that your knees are resilient and stop protecting it.
Yep. Yep.
Yeah.
Get
Um,
that stuff.
But anyways, we're close to the hour mark, so I don't know if we have like maybe we're gonna probably end this around like 4 o'clock. But I don't know if you have any like if there's any like last questions that we want to answer. And I haven't really looking at the chat too much, but I don't know if you have like a juicy one that we might want to go into.
No, I mean, there were so many good ones. I mean, we could talk about this for obviously years, and then we designed 7 courses around this. But I think what's the most important thing is that load, load, load. Like, let's get things stronger and more stable because at the end of the day, like, if you have that work capacity and you have that tissue strength, then you're probably less likely to get an injury. You're reducing your risk of sustaining something like that, at least when it comes to a tissue-related injury. Now, there's things that happen, people come at you, they hit you, you tear your ACL. That's not what we're talking about. We're talking about like
That's a freak injury.
that internal capacity standpoint. If you increase that, then you reduce your risk of just yourself having a tissue injury.
Yep, that's a good thing to end with. Yeah, I mean, I'm gonna say it in another way, like strength, like strengthen your knees more so than stretching. I would argue that strengthening is much more important. And while stretching is a type of load, it's not going to prevent you from injury. So you need to strengthen your body. I would say single leg work is paramount for a lot of our athletes, especially multi-directional athletes or even runners. Even though they run straight forward, you're still a lot of these. It's a multi-dimensional sport still at the end of the day. So yeah, strengthen those knees. Your body will appreciate it. You'll be able to last longer in your sport. But yeah, I think that's why we get along because we both believe that load is the name of the game, and it's all about just symptom modification and then getting our athletes back to what they love as fast as possible. But understand, pain is a multidimensional experience, so don't discredit the fact that these structures, even though they have structural capacity and you have the strength, you still need to be ready psychologically to play the game again.
Absolutely.
Yeah. Anyway, Stacy, it's been fun. This was super fun. I'm actually like I'm ready to like kill it. I'm gonna do leg day later today. But yeah, just to kind of end this, Stacy, like where can people find you? Like what are some ways that they could potentially work with you? What services do you provide? Do you mind just sharing that?
Yeah, so I'm on mostly on Instagram at the PhysioFix, and then the link in my bio kind of has everything that you need. I do like online programs, like template programs for various things. I also have like online consultations, and then I can create the custom programs. Or if you happen to be in Phoenix, Arizona, then you can schedule directly in person right there as well with me. Or actually, I have other providers too. So if I'm not available, they're amazing as well.
Yeah, I'm jealous. I want to go to your gym one day. I'm like, dude, I gotta visit Phoenix, just kind of visit, and we can like kick it and like
Yeah.
just squat and do a whole bunch of things. That'd be fun. Um, once maybe once my baby gets older, he's 8 weeks old. He's 2 months old today, guys. So he's a joy. But yeah, I'm in San Francisco, guys. So I actually do online programming as well. I have a pretty large program called the Pain Free Academy. It's just to like really teach people and give people the tools necessary to take care of themselves long term. And then if you are in San Francisco, and if Stacey, if you're in San Francisco, I work at a gym called Body Mechanics, and a lot of the personal trainers out there, we believe that barbell strength training and blending rehabilitation with barbell, kettlebell, and dumbbell training, that's the way to go, especially with some of you guys that are struggling with knee issues. But yeah, you guys can see me in San Francisco as well, and I'm happy to see you in person. So anyway, Stacy, this invigorated me. I'm really excited. Hopefully, you guys are ready to crush it, and you guys have just a rejuvenated sense of doing more. Not protecting us much, not bracing, but just embracing the fact that we are human, we are resilient. Do you have any final words at all, Stacy?
No, I guess someone just came in. All the dogs. But yeah, that was good. I think that we educated people a lot, and that's what our platforms are for anyway. So I'm glad we did this.
Okay. All right, everyone. Take care and have a great rest of the day, and keep training. Keep crushing. Okay. Bye bye.
Bye.